enshrined in CBC policy, but the state policy for people who want to follow up on this is called Conflict-Free Case Management Policy, and the number is HH0012. So this is the primary document that we have been working off in the presentation of the preparation of this presentation. We're looking at that document, but we're also looking at the CBC policy documentation, which essentially mirrors what is said in that HH0012. The presentation, we're going to define conflict of interest. We're going to provide guidance on how to avoid conflict and keeping members' rights and needs as the primary driver of care management. Next slide, please, Ingrid. So definition then. So if we were to start to define a conflict of interest, a conflict of interest is a real or seemingly incompatibility between one's private interests and one's public or fiduciary duties. So the conflict arises when there's this incompatibility between these two things, between the private and the public. So what's an example of this? So a conflict may arise when the same entity, so for example, a care management organisation is providing case management services, and rather than provide the member with a choice of, with a range of other service choices available in the community, they direct the member to, say, a HCBS provider within their own organisation. That would be deemed to be an example of an incompatibility between one's private interests and one's public fiduciary interests, right? Now, of course, you would say, well, there's plenty of organisations that provide care management and within the same organisation provide HCBS services. So the very existence of that environment does not necessarily suggest that there is a conflict, because as we go on through the rest of this presentation, we're going to be talking about things that we refer to as firewalls. So how you can begin to partition off activities within your organisation to ensure that, you know, the care management component is separate, under separate management and separate supervision to the HCBS service component, for example. And these sorts of things are built into the policy to ensure that there is a capacity for care management and care management agencies to manage this conflict, given the understanding that, you know, these organisations have different setups and different arrangements with regards to how they're undertaking both care management and their services. So the point is that the very fact that there may be examples of organisations doing both is not necessarily evidence of a conflict of interest if we follow the 9 principles that we're about to discuss, and if we follow good practice in terms of establishing the necessary firewalls to ensure that these any potential for conflict is minimised. So when talking about potential for conflict, Ingrid, could we just jump onto the next slide, please? So these would be some examples of potential conflicts that we sort of alluded to a little bit in the previous slide. So one is self-referral. This is one that I think is one that would come up the most, and one that we probably need to be the most mindful of. So when an organisation provides both case management and direct services, there's a potential for conflict of interest to arise. So let's say that there are 2 other outside organisations that could provide HCBS services to the member. If the case manager has a potential incentive to refer people to services within his or her own organisation, or services that benefit him or her personally somehow, there may be potential for a conflict of interest under these circumstances, right? From another perspective, there may be interest in retaining the individual in agencies or services rather than promoting independence, all right? So this whole conversation is about self-referral is basically in the interests of an organisation, potentially, but not in the interests of a member. And as we go through discussion, the idea would be that you really have to give the member a choice and demonstrate that member choice has been provided as you go through the work, you're documenting it in your file. So again, you can see that there's potential, but there's ways of mitigating that potential risk with self-referring and self-steering. Quality oversight, so building on the same example, another case management role is to assess the performance of service providers. So in this instance, there's a potential for conflict of interest for the case manager in ensuring that supports and services are provided in a high quality manner in accordance with the service plan. So if you were providing case management services, and you're also providing the HCBS service part of it, then you have to be very sure that you can still satisfy the requirements for all case managers, that they can still fulfill that important role of overseeing and making sure that the services that you've referred the member to are being delivered to the member at a level and at the level that that person requires, and at the quality that that person requires. And all this is saying is that if you provide both of these, you have to be very careful that this is not creating an environment within your organisation where care managers are not able to independently provide that assessment of performance for the services that we've been referring our members to. Okay, there may be a whole range of reasons why a case manager may be more reluctant to comment on services provided within the same organisation that they sit versus organisations external to them. And then the last point I wanted to make around this is around fiduciary responsibility. And that basically means our responsibility to manage the public purse, so public money. We all make that commitment in the human service industry that we will diligently and ethically manage the public purse without self-interest, okay? So this fiduciary responsibility does not allow for any conflict of interest whatsoever. So if there's any opportunity for self-interest or the perception of self-interest, our fiduciary responsibility by definition does not allow for it. So it has to be dealt with. And how you deal with it is through full disclosure. So if you have a conflict of interest potential like that one I said, where you can be referring, you have a member who has a service need that you think can be met through an internal HCBS service, then you need to be very open in your communication and your documentation that that you've had a conversation with the member about this, you've completed the necessary forms, which Marlon's going to take us through in a minute. But that's all been disclosed to the member, and that ultimately, at the end of the day, it's the member's choice to either stay within or to look externally for those for those services, but we will be providing a protocol for how you begin to address this this idea of self-interest. So I think this might be a good time to define conflict-free case management. I've given you a bit of an overview of the federal and state context for this. We've gone through the definition of conflict of interest, and hopefully I've provided you with sort of some framing examples for how the potential for conflict of interest is there when you start talking about self-referral and start talking about your role with quality oversight and your fiduciary responsibilities, both ethically and legally. Ingrid, let's jump on to the next slide and we'll do a definition of conflict-free case management. So conflict-free case management, when the same entity is both assisting the member to gain access to a service and also providing services to that member, there must be appropriate safeguards and firewalls in place to mitigate risk of potential conflict. And that's what we're going to go on and talk about today. So if there is that potential for conflict, you know, what are the practical things? What are the practical safeguards? What are the practical firewalls that we put in place essentially to mitigate that risk of that potential conflict? And we want to mitigate that risk because we want to mitigate it because of our professionalism as care managers. We want to mitigate it because we don't want to expose our organisations, and we want to mitigate it because it's the ethical and required thing to do. So let's then turn now to these 9 principles, because these are really the things that are going to help us to frame our response. So if we talk about safeguards, if we talk about firewalls, let's jump into these 9 principles, and they're going to really be our signposts that are going to point us in the right direction. None of this stuff is rocket science, but it's important that we pay attention to each of these steps as we go. So Ingrid, let's jump onto that next slide. Thank you very much. So what this slide is showing is it's basically showing the care management activities on the left-hand side: assessment, eligibility, resource allocation. And then it says, well, you know, if we're doing these functions, there needs to be a firewall set up with plan development, and then and service and monitoring. And then there needs to be firewalls set up between direct supports and service delivery. Now you could get more intricate and you could divide each of these functions up, and you could add more and more firewalls between each of these functions. This is just a very simple, hopefully a very simple illustrative of how you would basically want to put in mechanisms in place to ensure that HCBS services are separate from our care management. And the principle 1, it really talks about HCBS service level of care determination is separated from HCBS delivery, right? So what this is saying is that individuals responsible for assessment and conducting HCBS eligibility determination for services, they must do so distinctly and separate from the provision of those services. So an example, a health home care manager responsible for conducting HCBS eligibility determination for the provision of services, that's provided by a separate entity. So the health home care manager gathers the necessary documentation to determine that the child and youth meets the HCBS required elements. However, the HCM nor other staff related to the health home can provide the diagnosis, for example. So this is provided by a licensed practitioner, and it's one example of how you would set up a firewall. Okay, so you know, we do our assessments, but then an approved licensed practitioner provides the diagnostic side of the equation. There'd be another example of a firewall where the MCO approves care management recommended frequency, scope and duration. So we put up those recommendations, but then there's a separate approval process that goes through CMAs. These are all evidence of things that we've built into the system to minimise any potential conflicts. Firewalls, so therefore, you know, they ensure that there's no incentive or influence for care managers to affect the revenues of their organisations. So individuals making eligibility determinations should not have concurrent responsibility or oversight for finances or service provision at the provider level. Okay, so at this point, it's timely to discuss the federal and state expectations concerning care management. We provided some of the broader sort of policy framework, but we just wanted to pause momentarily just to give participants a sense of how this rolls out at the state level and at the organisational level. So next slide, please, Ingrid. So to help negate the conflicts, the feds and state have said that services must be person-centred and based on choice. All right, this is really the cornerstone, I think, to this morning's presentation. So what do we mean by personal-centred planning? So individual goals and preferences of the member take priority. So if the individual goals and a person-centred planning process is honoured, there's less potential for conflict in the case management process, as the individual's needs and preferences dictate the care plan and delivery of services. Right? What an eloquent solution to the problem. If we basically ensure that our services are person-centred, then the potential for conflict in case management process is limited simply because the individual needs and the preferences of the member dictate the care plan and dictate the services that they want to receive and who they receive those services from and at what level of intensity as well. It's all driven by member need. It's not driven by the needs of the care manager or the needs of the organisation or some other interest. You know, we spoke about fiduciary and other things earlier. So the second important point to make then is member choice. Wherever possible, members must be given the choice of their service provider, whether it's the same agency for care management or other direct services, as long as the choice is clearly documented in the progress note, including discussion of any potential conflicts that could arise. Now, this may not always be possible if services are limited to a particular geographic location or limited by cultural or language restraints. But the message is that choice remains a central tenet. Okay, so we have some of our colleagues on Staten Island who say to us, well, you know, there's very few games in town in terms of HCBS providers. So, you know, some of our organisations provide more of a soup to nuts approach, care management and the delivery. Again, the important thing to say is, well, we don't want to, because services, if it's a choice between a member being able to access a service and not being able to access a service because of either its availability in particular locations, or there might be an agency that specialises in particular language, Mandarin speaking, for example, then we want to be flexible and make sure that that service is available to the member. But the idea is that we document, and then we document some more, and then we document again. So in our progress notes, we're going to be basically saying that, you know, that the choices were limited. This was all explained to the member, and the member was given these options and the member decided that it was in their best interest to choose this option. And Marlon's going to take us through some of those documentation needs in a minute. So as we go through again this morning, just keep in the back of your mind person-centered planning and member choice of provider. And then again, we just emphasise is provided without undue conflict of interest. All right, let's jump on to the next slide, Principle 2.
And I think that's my slide, Brendan.
Thank you very much, Marlon.
Not a problem. Thank you, Brendan. So keeping in mind what Brendan had just mentioned, particularly to the definition of what conflict-free care management is. And if you remember back on slide 4, he talked about the potential conflict, whether that may be self-referral or self-steering or quality oversight or fiduciary, lead us into this principle where health home care managers must not be related to the child or youth. They must not be a paid giver or anyone financially responsible for the child or youth. So in essence, what are we saying? That we're saying that staff cannot perform the assessment. They must not be related by blood or marriage to the member. The member must be empowered to make financial decisions for the served members, whether that may be the power of attorney or a birth parent or a guardian. They must not hold a financial interest in the direct service provider. They must not be a paid caregiver to the member, and they are not financially responsible for the member. So again, keeping the concept of what conflict-free care management is, if any of these arises, then you have to disclose that. You have to bring that to the supervisor to let them know that there is some interest here and there has to be a separation, building on what Brendan spoke about earlier in the firewalls, that there has to be firewalls in place that will prevent these conflicts. Next slide, please, Ingrid. Okay, and so principle 3, there must be a robust monitoring and oversight established by the health homes. What are we saying here? There must be a statement specifying the child, youth, or the family member has a right to make an independent choice of HCBS services provider through the freedom of choice form, which I'm going to go through after this slide. There must be monitoring to ensure that there is no conflict based on what we just talked about earlier. Lead health home have Cfcm policy requirement for network partners, and that the health home must verify that all CMAs have a policy in place. There must be evidence offered to the member, the right to make the decision of an independent choice of providers. This must be documented in the progress note. This could be evidence also in the plan of care that demonstrate different providers or noted in a progress note that service offered. And this is the member's decision in making that is associated with their choices. Again, the emphasis on documentation, and there's documentation that the member or the legal guardian was informed about the freedom of choice provider, was informed about the form. All right, so in terms of what does that look like in terms of monitoring and oversight? So when undertaking file reviews or when supervisors are signing off on any plans of review, they must ensure that there's a freedom of choice form that was completed and attested to. There must be a list of agencies that was provided with similar services. There must be a statement specifying that the member has a right to make an independent choice of service providers. This may be in your welcome package. There must be monitoring and oversight, and that must include data collection of some sort or data evidence of external referrals documented in the progress note. And if an agency provides both case management and assessment, it must specify methods of communication required to inform their members about the potential for conflict. Again, what I just outlined is, again, as it says, a robust monitoring of oversight. These are the oversight that must be in place to ensure conflict-free care management. Next slide, please, Ingrid. So many of you are familiar with this form. It's the DOH 5276, and it's the Freedom of Choice form. And this form is very important because this is where the care manager documents where they have discussed with the member. They have discussed with the member their rights to choose their providers, any providers that they want to. It also states that CVC is reviewed to ensure that care management agencies are in compliance with the state expectation. It is also critical in meeting the quality assurance audit requirement. So we're just going to spend, in the interest of time, we're not going to go through the whole form, but again, this form must be discussed with the member. They must be afforded the right to choose their providers, and there must be evidence of this in their document, in their file. And a copy of this should also be uploaded to the external documents within GSI. Okay, which leads us into the next slide. Thank you. Principle 4. Health homes have developed clear, well-known, and accessible pathways for the child, youth, parent, guardian, legal authorized representative to submit grievances or appeals for assistance regarding concern about their choice, the quality, the eligibility determination, or service provisions and outcomes. So what does this look like, and what are we asking of you? Health homes and the CMS must work collaboratively to establish guidance and appeal mechanism with responsibilities to the providers, payees, and state agencies. So a grievance. So if a member has a grievance, and I'm glad you asked me what is a grievance. That's any complaint or dispute expressing dissatisfaction with services, decisions, and our providers. So if a member or the legal guardian has any grievances, these are the steps that they must take. If they believe that there's a conflict, information must be provided during a case conference, and you can reference that in the CVC policy, policy number B-5.3, or any other setting where collaboration with service providers are occurring. The CMA is responsible for internally addressing and resolving inappropriate services. The CMAs may also involve CVC in any circumstances that they require additional resolution of conflict services or safeguards to ensure conflict-free services. CMAs can call the CVC's 24/7 compliance toll-free number at 844-718-6396 to report any violation in conflict-free services, and CVC will respond and provide assistance. And again, this policy is referenced policy number A.1.5. And lastly, in terms of talking about grievances, we do have a resolution process. There's a written policy in place which addresses grievances, and the process is explained and is detailed. Once CVC gets involved, and when there's a resolution, CVC will notify the CMA that we've received the complaint and that we're addressing it, and then we will try to come up with some resolution on behalf of the CMA. If the CMA believes that the conflict-free is not being provided, the information is not being provided in a case conference manner, CVC can also, there are circumstances which may require additional resolution of conflict safeguards, and this again is referenced in the CVC policy, policy number B-5.3. And the next slide. And again, as we spoke about, Principle 5 addresses grievance, complaint, appeals, and result decisions are adequately tracked and monitored. And that's just saying that we track and we monitor and we provide feedback. And Brendan, I believe the next slide is yours.
Thanks, Marlon, for that. So principle 6, to ensure that consumer choice and control is not compromised, the department will oversee HCBS LOC eligibility determination and HCBS business practices. So what this is referring to essentially is that the State Department of Health will provide oversight and monitoring, and that there'll be random or targeted sample audits to determine whether assessment, eligibility, determination findings match actual service needs. So the upshot of this is that Marlon had spoken eloquently about the need to document. We can't emphasise that enough. You really have to, if you believe, based against any of these principles that we've reviewed this morning, that there is potential for a conflict of interest that either may compromise you or your organisation or the member in any way, you want to use two means to address it. One is you need to discuss it with your supervisor, and the other practice is just to make sure that the progress note and the care plan are illustrative of and demonstrative of consumer choice. If you have touched both of those bases, then you're going to go a long way to minimising any potential issues that that you may otherwise encounter rising from a random or targeted state audit of your records. So please be mindful of that. That's probably the largest takeaway that I'd hope that everybody would pick up on this morning based on today's training. Ingrid, let's jump on to principle 7. Agencies must have in place quality systems to ensure that CFCM has been provided in accordance with expectations, okay? So this is basic, this slide is basically saying the department will track and document the child use experience with measures that capture the quality of care coordination and care management services. And specifically in the documentation, they talk about the data that's collected and documented. We have discussed that in the context of assessments and plannings. But they also talk about member satisfaction, freedom of choice, and referral patterns. And they're basically saying here that within your organisation, you have to have a way of tracking your success against these measures, so that if there are potential conflicts, that you have a way of identifying those within your workflow, and then in the quality terminology, we would call them red flags. You have a way of red flagging that there might be a problem, and that you have a capacity or infrastructure in place on the ground in terms of your quality departments, your compliance departments, your finance departments, to be able to review that red flag and take the necessary steps to minimise, to resolve the issues and put in place a solid work plan moving forward to minimise the potential for repeats of some of the issues that may have been identified through this quality process. Let's jump on to the next slide, please, Ingrid. Principle 8, in circumstances when one entity is responsible for providing care management and HCBS delivery, appropriate safeguards and firewalls exist to mitigate risk of potential conflict. Well, we've spoken a lot about this. We've spoken about the need to have, first of all, you want to make sure that you have a agency policy in place. We've steered you towards the state policy. We steered you towards the CBC policy. You need to have a policy position in place organisationally. If you don't, you need to have one that addresses conflict-free case management. You have to make sure that you have the infrastructure in place to ensure that your care management activities have been documented adequately in the context of these expectations. And the third point being that the member has the right to be notified of potential conflicts, and that all of this is disclosed in a proactive way. If you recognise conflicts, you disclose it in a proactive way to the member, and you disclose it in a proactive way to the supervisor, and then the supervisor seeks additional consultation if necessary. Next slide, please, Ingrid. So principle 9 is the last principle they give us to help us to think through all of this stuff. Meaningful stakeholder engagement strategies were implemented, which include child, youth, family member advocates, providers, state leadership, and HCM. So it's basically saying, well, once we have all this workplace, this stuff sorted out at the agency level, at the care coordination level between the care manager and the member, that we also need to make sure that we have a network and of stakeholder providers and the leadership, and we're involving all these people in the decisions we make to ensure that we are continually improving our performance with regards to conflict-free case management. You know, all these people have a seat at the table. Family members, family advocates is a really growing area in our sector, and we need to be talking to them, because these are people that hear about problems or issues that arise, and that can really make an important contribution to helping us as a network of people involved in health homes to really improve the system and make it better. So just some points surrounding, including child, youth and their advocates in the evaluation of current infrastructure. Again, that's another theme in the industry I've noticed over the last 10 years, this idea of actually involving people who are receiving the services in the evaluation of services. Very important. A review of your policies and procedures. And then there's also, obviously any activity, organisation activity has sort of flow-on effects in terms of costs and perhaps unintended consequences when implementing firewalls and things along those lines. So, these are just things that you would include as part of your, broader system review. So that concludes the presentation on conflict-free care management. We have a number